Good afternoon. My name is Dr. Jaime Merchan. I am an associate professor from the University of Miami Sylvester Comprehensive Cancer Center in Miami, Florida. I will be talking with you today about some highlights in regards to genitourinary oncology trials that have been discussed at ASCO. The first trial I would like to talk about is a very important phase 3 trial that actually is practice changing in prostate cancer. And this is the Latitude trial, which is a phase 3 study, randomized, that is comparing patients with high risk metastatic prostate cancer with either androgen deprivation therapy plus placebo or androgen deprivation therapy plus abiraterone and prednisone. This was a very large study, and the results of the survival data were presented. This, in a nutshell, this is a very positive study that showed that early addition of abiraterone and prednisone in patients with newly diagnosed high-risk metastatic prostate cancer is associated with a significant prolongation in overall survival compared to ADT alone. And this study was very positive both in overall survival, radiological progression-free survival, and many of the other secondary endpoints. And the hazard ratio was actually low, about 0.63, and this is more or less comparable with the hazard ratio seen in patients receiving upfront chemotherapy and ADT. So this is an important trial that should be and is practice changing. A study also was presented in regards to bladder cancer, and this was the Keynote 0.45 trial that was a randomized trial in patients with metastatic or advanced bladder urothelial cancer, and they were randomized to either second-line chemotherapy or pembrolizumab. And this study actually showed that the primary endpoint, which was overall survival, was significantly prolonged in patients in pembrolizumab compared to chemotherapy. This is important because this is the first immunotherapy trial in bladder cancer that is showing a level 1 evidence of a clinical benefit, meaning a benefit in overall survival. So this basically establishes immunotherapy, and in this case pembrolizumab, in the advanced setting in patients with cisplatin refractory disease. Finally, I would like to talk about some important studies in renal cell carcinoma. One study was exploring the efficacy or the activity of pazopanib in the adjuvant setting, and Dr. Robert Motzer presented this study. Was a large study where patients with high-risk resected clear cell renal cell carcinoma were randomized to either placebo or pazopanib for 1 year. In a nutshell, this study did not meet the efficacy endpoint, which was a disease-free survival. And in addition to that, pazopanib at the regular doses of 800 milligrams per day was shown to be toxic to a point that an amendment had to be done in order to decrease the dose of pazopanib to 600. So this study did not show that adjuvant pazopanib was associated with decrease in the risk of recurrence. And I think it's worth mentioning some of the upcoming studies or promising trials in renal cell carcinoma that are using a combination of immunotherapy and anti-angiogenic therapy. And the two interesting studies that were presented were actually early phase 1/2 studies that show that combine either axitinib, and avelumab, which is an anti-PD-L1 antibody presented by Tony Chouri, who showed that this combination is associated with actually a very high response rate in the 50s and a good toxicity profile. A word of caution in one study that was presented, which is important to show also negative studies, especially in regards to safety. There was a phase 1 study combining pazopanib with pembrolizumab. And that study actually had to be stopped early because of significant liver toxicity. And this is important because this corroborates the safety issues with pazopanib in combination with PD-1 blockers, as a prior study combining pazopanib and nivolumab also showed significant liver toxicity. Thank you very much.